So this next section that we're looking at is looking at placements and the tariff. So the standards that we're having to come up against, some are going to be easy to do at placements, some will be natural to be able to do, others won't be so natural. So we're having to use a combination in our education of what we can do on placement and what we're going to have to do simulated, and trying to bring it up from that way. So when we're thinking about simulation, what we're doing is we're trying to think of a controlled environment. So perhaps actors, we have mannequins at the university, staff, expert patients who are going to come in and act a certain way. We already use a lot of that at the minute. So for example, when our students are learning about learning disabilities, we actually have people who either are expert patients or carers or actors who come in and are able to act in a certain way. Now, personally, I will be very surprised if they manage to do an entire placement period with anybody and they don't come across an angry patient. But should they still need that as part of their collection, then what they need to be able to do is that we can create that environment for them. So we will be using simulation alongside placements, firstly to be able to encourage them to learn safely from their mistakes in a very specific environment, where they can get extensive feedback and they're able to be prepared before they come out, but also to make sure that it's standardised in cases where we might not be able to create that for people at the other end whilst they're actually in practice. On their placements, what we're going to be looking for is to use the resources that are quite difficult to authentically create in a mannequin situation or different ideas. So what we're thinking about there is actual patients and their complications and their nuances. Perhaps trust guidelines or formularies, where we can have some of those but not necessarily all of them, and other clinical staff. So actually meeting the multidisciplinary team in some areas or to work from there. So at that point, we would obviously be expecting them to reflect. So reflective practice is really important. And it's the difference between a standardised patient and real patients. So the difference between that. And I think that that's really different. The ability to do standardisation gives us that quality assurance of the standards. But actually, if we're thinking about the higher orders of Miller's pyramid, Miller's triangle, but the shows how and does, that's going to have to be non-standardised situations for some people. So I think that's what's really important. So when we're looking at the sort of simulations that we're looking at, what we're going to be doing is we're going to be looking at sort of mock pharmacy. So we have a mock pharmacy and we're going to be looking at sort of community-based. And I should say some of my colleagues are here in the room who we've worked with. We've actually had the funding to do a pilot of some of the placements. So we've been able to do pilot placements in both a mental health trust, in an acute trust, and also we self-funded some GP practice placements as well to try and allow us to have a look at those different things. It became very clear to all of us involved with that actually the students in the first and second year just didn't have the skills and the clinical knowledge to be really making the most of the complex patients that they find on wards. Now, I'm a community pharmacist, so I would never say that community pharmacy is not clinical, and I just want to be very clear about that. I'm a community pharmacist with a clinical diploma. I very much believe that you can be a clinical community pharmacist. But what I would say is that the complications of some of the wards and some of the formularies in a hospital environment or in PCNs are very different to what you can see on a day-to-day basis. So the way that we have decided to work this through is that the focus on community pharmacy, where you can learn the regulations, where you can learn about POMs and Ps and CDs, are more towards the start of the programme, and then moving towards the complex patient at that point, because we know that there is not an infinite resource of placements for everybody to be in everywhere at the same time. So our simulations reflect that, which means we're looking at simulated mock pharmacy, and then we're able to introduce them through a simulation to ward-based work, multidisciplinary teams during the second year before coming out. We're starting to look at blood work, clinical observations, because students need the basic background of physiology and pharmacology to be able to deal with that later on. We then start to look at complex ward-based planning. We start to look at the management of biochemical or clinical abnormalities, clinical handover. We actually do a simulated aseptics lab in the third year as well, which is important for aseptic manufacture. So we ask them to not only make a product, but also decide from a QC point of view whether or not they would actually allow that to go out to the patient. So for example, if they realised at the end of it that they've done a 1 in 5 dilution rather than a 1 in 10 dilution, we would expect them to not sign that off for use for the patient. And then in the fourth year, we're looking more at public health, long-term condition management, medicines optimisation and complex cases. So I should say that all of the medicines optimisation and everything else, we still know that that happens in community pharmacy. So it's not that we abandon community pharmacy after the first and second year, but our thoughts change at that point. We just feel that the basics around POMs and Ps are better taught in that community environment. So the placements are broken down into different areas, and this comes sort of from a lot of work that we've done as pharmacy school councils across the way. So placement types, you can have different sort of experiences. And there is sort of the orientation type placement. And realistically, if anyone's ever been involved with placements with the University of Hertfordshire before, that's really what we've been doing. Orientation, observation. Perhaps the student would be doing a few case studies or something while they're there, but in general, they're stepping back, they're watching what's happening. And that's traditionally what placements have always been like. There is a real push that placements should no longer be like that. In fact, observation placements do not meet the requirements for clinical tariff. So that means that observation placements don't get paid. So that's why we're not doing observation placements anymore. From that perspective, the idea should be that it should be used for integrated learning, which is what I just talked about, that the idea of sort of a flipped classroom, that you're learning something out on the job, the experiential learning from that point, that they should be part of the workforce or even seeing sort of specialist areas, and they're the different types of placements that are talked about. The other thing that everybody's very keen on is having students doing what they are determining as entrustable tasks. Now, I should say that list of entrustable tasks is yet to be defined and will be defined with the stakeholders. But it's things like writing up in a CD register, doing a POM register, selling a P product, maybe doing some sort of medicines reconciliation. It doesn't have to be necessarily real. It could be mocked, but the idea is that they're actually doing something. Does that sort of make sense? So counselling a patient. In the past, we would never have expected people to be counselling. Now we would expect counselling under supervision, but we would expect there to be patient contact where there never has been before. And therefore, that has to happen to be able to do this assessment of competency. That's the key thing, is that we have to decide whether or not somebody is competent or not. I should say that the way that we have set our programme up at the University of Hertfordshire was with lots of talking with our stakeholders, and that most people felt comfortable with the correct training and the correct skills to be able to sign off somebody's being competent or not competent, because lots of people have been doing that for pre-regis for many years. So lots of people, if you say to them, this person needs to be okay at communicating with other patients, you're happy to watch somebody and say, yes, they are, or no, they're not. What we were told during our pilots and during the other information that we had and our focus groups is that people were not so comfortable with saying, I'm speaking to this person and now I'm going to award them a 60% mark or a 70% mark. Does that sort of make sense? So yes, no, competent or not competent. Actually, we're not going to use not competent, not yet competent. Very clear. Competent, not yet competent. Compared to a grading, which is why that final module that I talked about for us, we've decided that that's pass or fail. and that it doesn't actually count towards their degree classification. It's just that you are competent or you're not competent at that point. Does that sort of make sense? Yeah. So this is what we have proposed. We've gone from having approximately 10 days of placement across the 4 years to having 13 weeks of placement across the 4 years. You'll notice that actually we have 13 weeks and a half day of industrial placement. We're not including the industrial placement in the 13 weeks because that doesn't attract tariff as yet. They're very specific that industrial placements don't attract tariff. That's on top of the 13 weeks. But Wales, Scotland and Northern Ireland all determined what their universities should be doing with regards to the number of weeks, and they kind of picked between 10 to 13 was the range. So we went in with 13. Now I should say, I said before that the university has already gone through Part 1 accreditation. We went early. So we were one of 4 schools in England to go last year. The rest of them are going this year, some next year. So we went in early and we sort of showed our hand and said, this is what we want to do. Is this going to work for you? Which is why we're so far through at this point. And I know some of my colleagues who are doing similar things now are still trying to gather information to see what they want to do. At this point, we're past that, fortunately. So the way that we've looked at it is we have gone for a 5-day, 1-week placement in community in the first year, 3 weeks of community placement in the second year, but not as a block. And we've deliberately not done it as a block because we want it to be experiential. So we want them to learn some things, then go out and see it in community, and then sort of come back and then go out again and look at it from that perspective. Does that make sense? Because if it's 3 weeks, the only time it's going to make any sense is at the end of the year. And then in the third year, they will do 5 days in community where they're going to be starting to focus on services consultation frameworks, looking at things like that. 5 days in hospitals, and then 5 days in primary care, PCNs, GP practices, somewhere along those lines, working with different things, possibly even visiting a care home as part of that sort of idea. So what will happen is that the students will go out for 1 week to any one of these, and then the next placement period they will rotate round. Because that then allows us to sort of build capacity, because we only need a third of placement sites at any one time. So it stops it being quite so difficult for all of us and stops the pressure on everybody else. And then in the 4th year, they do something similar, but it's in 2-week blocks. So they have 6 weeks of placement, which is why we had to move the project out. Because the project used to last for 13 weeks. So that makes it very difficult. And we still want our students to be having clinical teaching before they go out on placement. So before they come out to the foundation year. So that's the idea between what we've done and what we're looking at that point. The other thing that was very strong is around IPE, so interprofessional education. We don't have a med school at Hertfordshire, which therefore means that some people believe that that's quite difficult for us to do interprofessional education. What I should say is that we do have lots of other students. So we're using our dietetic students, our optometry students, our physio students. We've actually got an ethical debate around the clinical and legal issues of end-of-life care that we're actually doing in combination with our law students. So we've got quite a lot of interesting things going on with regards to that, and also our physicians associates. So even thinking about consent, so a workshop around consent, what consent means, taking consent within a clinical situation, having examples of people not appearing to give consent and what that means and how we're tackling that. So that's sort of done in association with our physicians associates, and then we also have a medical practitioner in there as well. So we have lots of different examples about how we're doing that at the university, but also there is the opportunity for IPE on placement as well. And again, it has to be progressive, moving around. So in the first year on the placements, they'll have the understanding of the role a pharmacist in a community pharmacy setting around how that works. with regards to multi-professional colleagues, the sort of day-to-day contact that people have with different members of the multidisciplinary team. Again, the reflections on the interactions again in the second year with regards to that. In the third year, more ward-based multidisciplinary teams. Hopefully they'll be able to see perhaps prescribers in clinics if they're in GP practices, looking at different things like specialist nurse, healthcare assistants. And again, in the fourth year, building that up further. So they're actually getting to see people in these tasks and they're getting to see people in these roles. And I think that that's really important. The other thing that's really important for us is this idea that we're linking ready for foundation training. So we want our students to be building up a portfolio that they're going to be able to use when it comes to their foundation training. Because if they were able to demonstrate shows how at university, they've only got to move forward to does. And what we want is something that our stakeholders, the people who are going to be delivering foundation year training, are able to look at that point. So we're trying to align that with the HEE portfolio, and that's work that's ongoing at the minute. We're actually using some of our money that we've got from HEE to start a new type of electronic portfolio that we're looking at, where people, so you might see it if you have our students, where you can do electronic sign-off for competencies and for doing things. So there will also be the clinical teaching is we're making sure that that's aligned with the RPS prescribing framework. That's really important. Accreditations, obviously, for the mentor sign-off in professional portfolio. We want them to have experience in prescribing environments before they get to foundation year, and the expectation of what they're doing that. We want to make sure that they've got experience in patient consultations, both in simulation. So we're hoping that actually this increase in placement and this increase of different things is that I'm sure we've all had the student who's turned up on their first day of what was their pre-reg, maybe their foundation year, who struggles to actually communicate with people or hasn't seen an actual box of medicine before because they've been to pharmacies lots of time, but they've never been allowed to take one off the shelf and dispense it, or they've never been allowed to actually use the label printer. So, and it's not something we can teach because there are thousands of different labelling systems, so we can't teach every single one of them at the university. So it's really important. And also to make sure that they're used to working with colleagues in other healthcare professionals, that they understand that actually it's not that pharmacists are better than any other healthcare profession, that we're part of a multidisciplinary team. I think this kind of comes back to one of the questions that we were chatting to before then. So we were talking about quality assurance. So we've had to promise both the university and the GPHC that we will have quality assurance of these placements. And that comes from both a perspective of what everybody gets, but also that everybody's getting a similar experience, which is quite difficult. So we have to think about the sort of recruitment, selection and appointment of our sites. So we have lots of audit forms. Zoe already alluded to earlier the fact that there are lots of contracts. We have to come out and check everything. It's all part of this of the system to say that we can do that. That we're going to be providing training for everybody, so everybody is equipped in the same way to be able to be upskilled for that. That people know how to give feedback. We're also training people with equality and diversity. It's not a nice thing to talk about, but there is a massive attainment gap in pharmacy. And there was another published result about the differences between the awarding gap for both the MPharm degree, but also how people do in the registration exam. And it's, are we creating barriers for that within our placement sites? We need to just make sure that that's something. It's a difficult conversation to have, but it's an important conversation to have. That because students are going to be spending more time on placement than they used to, there's going to be an importance to make sure that things like well-being and support that would normally be happening at the university if they're out for 2 weeks, we need to make sure that that isn't lost whilst they're out on placement. And also we're monitoring and evaluating, but also from your perspective as well, that we are still maintaining patient safety because we're letting people out to do things, and I think that that's really important. The last thing that I wanted to just touch upon then is the clinical tariff. So it's paid, the payments for these is paid by Health Education England. It's no longer, so at the minute we fund our own placements. We've funded our own placements out of our own pot of money. And that's why there is a difference. So the placements will no longer be funded by UH, even if that's where your money will appear to come from. They're funded by HE because pharmacy for the first time has gone on to what's called a clinical tariff. So there are two types of tariff for placements. There's medical tariff, which as you can imagine is a lot of money, and there's clinical tariff, which is everybody else, and as you can imagine is not quite as much money. So we're the same as nurses, we're the same as physios, dietitians, everybody. So there are set rules as to what constitutes a placement, what doesn't constitute a placement, whether or not you can claim, whether or not you can't claim. Okay, and I think that that's really important. The actual amount of money is £5,000 plus something called market force factors, which we have yet to find out what exactly they are, but, obviously. But the general consensus is that it's probably about 7% on top of that. And that £5,000 is if somebody is with you full-time for the full year. And full-time for the full year is 40.8 weeks at 37.5 hours a week. So if you work it out to about 30, if you work it out as 7.5 hour days, by the time you've taken into account your market force factors, you're talking about £25 a day per student. And that's where we are with that. And it's not something I can negotiate because it's something that has been negotiated in Parliament. It's coming from the NHS money now, so that's where it's coming from. What you need to be aware of is that the payments are made in hours, not in days. They are made 3 times a year, and as a university we used to pay after each they used to go out. So there are only 3 times during a year that they're able to claim, and how you claim is completely dependent on the sector that you work in. So actually most trusts and some GP surgeries, some PCNs already have an account with HEE, which means that they are already receiving payment for education for different types of education. So we put in 3 times a year, we're asked how many hours have gone out. And then if you already have something with them, they then send that out to you. You say yes or no, we agree with this, or there's a discrepancy, and then the money comes straight to you. If you don't have something like that, which means that you are normally a community pharmacy, for example, at that point you would have the payment would go through us. So we would claim on your behalf, and then we would send the money out to you once we've got the money, if that makes sense.